By now, most of you are aware that CMS yesterday released a what appears to be a several hundred page document regarding what we need to do for the application. With me, the governor was very clear. He wants to maximize the opportunities for Indiana to receive as much money here as possible. So we're intending to do that. So I've got a 4 o'clock. That doesn't necessarily, we're scheduled till 4, but for those who want to stick around, are you willing to stick around a little bit?
Absolutely.
Okay, so you can continue without me. Dr. Weaver has to leave at 3:30, I believe, so she has some comments that she wanted to make. So we'll start with Dr. Weaver, and then I'm going to turn it over to Eric to monitor the rest of the conversation. Lindsay?
Okay. Real quick, sorry, I'm going to flip it over to her in just a minute. Here's our agenda. So we're going to go through the overview real quick of the application, and then I'll turn it over to Dr. Weaver for some ideas and thoughts, and then we'll go around to the working group. So as Secretary Rowe just mentioned, the notice of funding opportunity was released yesterday. So we're furiously looking at, what it is that we need to do and how we can collaborate and get things going. There's a lot of information requested. One application per state will be accepted. FSSA will be submitting the application through grants.gov, and the application is due November 5th. The main objective here is supporting rural communities to improve healthcare access. I think everybody already knows all of this. The 5 strategic goals are important to keep in mind because we have to keep tying all the initiatives back to these strategic goals. So as we get more into what some of those initiatives might look like, we continuously have to tie them back to these 5 strategic goals. Again, all this was, it was sent out to the working group in an attachment, but it's also on our website. If you haven't had a chance to look at the application, the information is out there on our website. Again, the proposed initiatives must describe which strategic goals align with the initiatives. And then the funds distribution, real quick, they've asked for all states to just assume $200 million per year. In some states will get more, some states will get less. It will depend on who applies. It'll depend on the workload funding is the biggest factor. So the baseline funding is split equally among the 50 states if they all apply and are approved. And the hope is that from CMS is that all will apply. If you're online, if you could go on mute, that would be helpful. Thank you. So that's where the first 50% will be split equally. And then for the workload funding, that's really important. How we address the application to make sure it's thorough. They're very detailed and specific in how they want the application submitted, the content of what we need to submit. So we'll be focusing on that internally across IDOH and FSSA to make sure that we are meeting. And there's no back and forth. You submit the application and you better get it right because there's not a lot of room for error in that. So we will be diligently having a lot of people look at what the requirements are and how we meet those. So that's just really the overview of the process. And then the application itself, just keeping this in mind, and I think it's important to again, everybody can access the application itself and look at what the requirements are, but I think it's important to make sure that we are keeping this in mind, that we have to identify the needs in the target population. That could be all rural health hospitals in the state of Indiana. So it can be statewide, or it can be in these 10 counties for each initiative. So think in terms of that as we're talking about some of these initiatives. As I know there's concern, well, that's statewide, it doesn't apply to everyone, and it's okay. We can have a combination of different sets of initiatives, but the most important thing too is that they tie to those goals and strategies. It identifies the components required in the plan, but really we need to make sure that we can have identified outcomes that can be measured, because the money is guaranteed once you're approved, but you still have to keep up with the reporting requirements annually to make sure that we're using the funding and that we're measuring the outcomes as expected. So again, I think this is nothing new with any federal funding. It's just a lot really fast in a 6-week turnaround time. So wanted to make sure we were kind of level set. There's a lot of work going on. For some of us, this will become the full-time work, and that's okay because it's $200 million a year for 5 years is $1 billion. So next we'll switch it over, stop sharing, and then I'll share your presentation. I'll turn it over to Dr. Weaver.
Thank you. I appreciate it. So I've been really thankful to get on many different calls with HHS, CMS, different organizations, and hear from the administration on what they're looking for and the things that they're excited about. And I'm really thrilled that many of the components are focusing on. We already have really great momentum happening here in Indiana, that this can really take us to that next level. In the application specifically calling out, of course, technology, EMS support, our efforts in the Make Indiana Healthy Again space also will come into play here, and we shouldn't be looking at these things as separate, but really how could they be additive? So listening to those calls, knowing what we have going on here in Indiana, some of our opportunities, I did just want to talk through some ways that we're thinking about it from the public health standpoint. You guys know this data as much as I do, but we have low life expectancy in our rural communities. All those dark blue are our lowest life expectancy counties across the state. We have high rates of obesity, related chronic disease, smoking, suicide, substance use. And we also know we have low access, so decreasing access to primary and acute care, prenatal and delivery care. And we hear from these communities over and over again that transportation, housing, and food access is something that they will look to address. When we talk to our rural hospitals and healthcare providers, we know those facilities have high fixed costs, right? You have to keep the lights on, you have to have people there and available, you do billing, et cetera. But they have low volume, and we know that is a leading cause of why many of our hospitals have stopped delivering babies. It's just simply because of that low volume. So what are opportunities to address that? So here are just some ideas, and again, this is thinking and talking and hearing from the federal administration what they're looking for. So these are just ideas that we're presenting as possibilities. So looking at the problem of low volume and that 20% of rural ED transfers are avoidable if you have teleconsult support. Many patients are transferred for that specialist, whether it be neurology or an ENT specialist, a hand specialist, different things that they don't necessarily would have to see if there was that teleconsult support. So solution would be increase and improve ability to keep patients at facilities, investing in technology at rural hospitals that will allow specialists to provide consultation services. And they're also looking for policy change with all of this. So what will be our sustainable plan? How do we develop and implement reimbursement models for teleconsults? The return on investment here is 43, and this is, I can give the references to this data too, 43% of patients treated and discharged locally with tele-emergency support. If a hospital can retain one patient a week, that could be up to $500,000 a year for rural hospitals. Avoiding the cost of transfer enables faster intervention, improves continuity with local providers, enhances safety and satisfaction. I get the opportunity to take care of many of these patients who are transferred to a higher level of care. They would much prefer to be at home. And of course, recognizing that here in this case, the upfront cost of investing into the teleconsult and building the system for that is where the most cost would be. Next, looking at telehealth, lots of different ways of thinking about telehealth. This could be telehealth in your home, on your phone. It also could be a teleconsult for our primary providers, again, recognizing there's low access to specialty care in rural communities. And then you bring in the transportation issues as well, and just decrease access even to primary care. So that low access, difficulty of transportation, you could leverage non-clinicians in the telehealth space and for lifestyle education, and then making that teleconsult availability, connecting our rural primary care with the specialists. Out-of-box solutions exist. I think something important is it is per year. And so there are things that we need to hit the ground running with each year. Some things might take some more time to build up, and I'll present one of those. But what are some out-of-box solutions? Remote biometric monitoring is also something I've heard brought up several times, health coaching, and as I mentioned, the teleconsult. Just recognizing too, and it's in here, looking to leverage existing brick and mortar. We don't have to go and build new places. Places exist in these communities. How do we transform A local health departments often have clinic rooms. Some of them are putting in dental chairs to have dental access. Many of them, looking to expand into strip mall areas. So how are we leveraging, working with our local economic development folks to identify those places that people, even if they don't have broadband at their house, what is a local brick and mortar that they could go to do some of this access? Interoperability, decreasing the high cost of unnecessary tests and improving quality. So estimated 36 billion of potential savings from device and data interoperability. Information blocking, or the stopping of sharing health data between different entities, is anti-competitive. Hoosiers often want to stay with their single provider due to the difficulty of transferring records between their primary care provider or hospital to hospital or preventative care, whatever it may be. And that inability to see a patient's records does lead to increased costs and potential harm. So we could invest in a statewide medical interoperability across all provider types. We were actually looking to do this to connect our long-term care facilities, which are currently not connected to our healthcare providers in Indiana. So anybody in the acute care system wouldn't have access to what's happening out, even just in our long-term care facilities, but also recognizing primary and specialist outpatient providers are not connected. So we could help utilize some of this funding to help our rural communities in that connection, and just thinking about policy as well. How could we engage the rest of the state in becoming interoperable? And of course, security concerns, HIPAA, everything else still applies here, but it is really that access to the healthcare records, no matter where the patient is interacting with the healthcare system. A regional medical operations center is something else that has been discussed. It is being implemented in other states. This is recognizing the great difficulty of transferring patients. Our rural hospitals, even if we do provide teleconsult, often patients will need to be transferred to that higher level of care. And this is a system similar to what they do here in Indianapolis with their mesh. And some of our systems have similar operation centers, but it would be a statewide center to help with the transfer of patients. It would not interfere with if a hospital typically would transfer to a specific hospital, but this is kind of the backup, right? It is your ER doctor in the middle of the night that's calling all the hospitals, trying to find the best location, delaying care, which increase costs. I see Eric nodding. We live this. And this center helps provide not only to provide support to the hospital, it identifies who's the right EMS. So many of our counties only have one EMS available, sometimes two. So they would be able to pull on resources from other rural communities. So you're not taking people out of 911 availability. And then also make sure that patients are going to the right location. So every patient does not have to go to the ER. We now have statute that allows patients to go to urgent care or to behavioral health center if that is the right place for them to be. So we can avoid some of these high cost locations with this center. I will just add, from a preparedness standpoint, it is also these centers that if you were to have a tornado or some kind of disaster, they help manage the movement of patients and ambulances. So it has multiple purposes. Perfect. Okay. And then workforce, huge component of this. Our Healthcare Workforce Council has been working and talking to rural hospitals, encouraging them to take residents for rotations. We do know when residents are exposed to rural care, they have a much higher likelihood of actually going back into that community and providing and going back to be a physician in that community. We know that new physicians in a community is an economic engine. They bring money, they bring employees, they help build up the economy of those communities. And really not just sticking with physicians here, but clinicians in general. How are we getting that exposure to working in a rural community, acknowledging that most of our training is happening in urban centers. Other states have done this and showed improved uptake of rural communities. So what does that look like? You can utilize funding to start. There's upfront costs of this for rotations, expectations for regions to develop plans for hosting trainees, also engaging in education for community health workers and IT support, which could bring a lot to a community, and there's just low access to those things in our communities. And then region grant making. I was on a call where they specifically mentioned the Suburban Hospital Organization and how they like the idea of these rural communities, the hospitals, rather than working in silos, and not just the hospitals, FQHCs, CHCs, whoever is providing care in that community, really working together for a shared sustainability plan, demonstrating collaboration, aligning across the goals. And you could, so a proposal would be that regional consortiums could come together for an application for this grant funding a year. That again, this would have to be right away, could be further down the line, working with everybody within their community, and then really making sure that they're addressing all the community's needs, such as identifying cost savings through shared billing practices, specialists, pharmacy contracts, ensuring that there's prenatal care within that area in all corners. So really kind of charging them to say, this is your geographic area. You as a group have to make sure that there's access to prenatal care. What preventative care is available? How are you getting preventative care out into these rural communities? Chronic disease management, remote monitoring for diabetes, leveraging mobile integrated health, looking at hospital at home programs and models in rural communities, whether that be in long-term care or actually at home. And then addressing things such as food, housing, transportation, medication, medically tailored interventions like produce prescriptions, school-based initiatives, and then also helping to address workforce. So just recognizing that different parts of the state are at different places with all of these things. So rather than saying all across the state is going to be a one-size-fits-all, allowing our rural communities to come forward with a plan to say we will address all of these areas and have a sustainability plan with the funding. And so just some examples, I already mentioned the prenatal care, but then also rural residents having difficulty with their preventative care and making sure that people in the community have access, whether it be mobile integrated health, sending people to FQHCs, how does a local hospital make sure that it's available. So just kind of thinking through what this could look like, and again, these are just all ideas. Year one, really focusing on those out-of-the-box projects, teleconsult, telehealth, interoperability, workforce, and then working on an RFP for those regional cooperative grants for years 2 through 5. And then just also wanting to acknowledge, we will have to collect data, have key performance outcomes for all of these things, and it should be part of this conversation. What do we as a state want to see improve with these healthcare dollars? In addition to access, we should also be looking for health outcomes as well. And then just wanted to provide some examples of some of the things that we're already monitoring and doing, how we're collecting this data, how it's being displayed, how are we going to make sure that Hoosiers can hold us as a group accountable for improving outcomes. And this is just an example of how our counties currently have key performance outcomes for their communities. And again, we should leverage some of this work that's already happening. And that's it. Thank you for your time. I apologize for speaking fast.
A lot of information to cover. So real quick, just since our last meeting, we met with the Indiana Broadband Office. We met with, or we've outreach to Oak Rock, and then the Indian Tribal Office, Indian Tribal Offices. So because it specifically identifies agencies that must, they at least have to have conversations with. So we're making sure that we're engaging even more people or more organizations in the conversation so that we're not missing anything that we need to be thinking about. So with that, I think Eric, did you have anything you wanted to add before we go into the working group ideas comment section?
No, I don't have anything to add, but I think this is the most important time of the meeting because I think we want to hear from everybody around the table what their thoughts are. You probably had a little bit of time to at least see the guides. I'm sure you probably haven't read it all, but you know that there are the 5 strategic goal buckets. There are the 11 permissible use buckets. I think what we would like to hear from those around the table and online, and Terry, you'll have to help me with who's online. All right, so I think we'll start online so that we don't skip the people online. We learned this recently, that it's a bad thing to skip the people online. So I think I saw Senator Good on there. Would you like to go first, Senator Good?
Hi, everyone. Sorry, can you hear me okay?
Yes.
No, I mean, I don't have anything to necessarily add. I'm amazed at how short of time we have to try to turn this thing around. But no, I mean, I appreciate the quick run through of, kind of the priorities and what we need to be focused on.
All right. Who else is online? Is Representative Barrett on? Representative Barrett, if you're on. I can't see.
Hello, this is Brad.
There he is.
Can you hear me?
Yes.
Yeah, no, nothing specifically to add. I agree with a lot of what Dr. Weaver said. I still have connected with some rural CEOs about this. And again, I'll say that I also feel like a big focus is preserving the footprint that we have. Department of Health has that location of trauma centers and acute care and the ability to triage, treat simple things, transfer complicated things, whether it's in trauma, acute care, or complicated pregnancies. And I really feel like a majority of what we're doing should be in protecting that footprint and that infrastructure. That's all I have to add.
Is there anybody else from the working group on there? I can't see the list.
Katrina.
I will go to the room first.
There are people on, so I don't know if you want to just give them an opportunity.
Let's go around to
That's fine.
the people from the working group in here first, and then we'll get back to everybody else. I think we can start right here.
Yep, I'm happy to start.
For those
So,
who aren't online, can you let them know who you are? Know
yes,
who you are.
yep, I'm Dr. Cami Wright from CareSource. And if I had to choose what really resonates for me, it's the pillars around technology. If you look at some of the things that Dr. Weaver suggested in some other conversations we have, I really think that technology is foundational to improving access. We have lots of models that we can build. I think that there's lots of evidence for both telehealth and teleconsults. I think there's applications in OB that helps to address some of the poor maternal and infant outcomes that we have. I think that technology involves an upfront capital cost, but less sustainability cost, so we don't get into the cliff effect that we talked about at the last meeting. So if I were to choose one thing to really focus our efforts on, it would be, again, those technological advances.
Anything, Lindsay?
I agree with the technology. I do think it's foundational. I think that will help in all of the other areas that were addressed. I also think focusing on workforce is important. Certainly in the Medicaid side, we hear about members that don't have access or members that have to travel for, further than what they would like to travel in order for that access. And so I don't think that we should ignore that.
I really appreciated the presentation from Dr. Weaver, but the one thing that really stuck out to me is the idea of regional grant funding. I think I'm really concerned about this opportunity where CMS expects us to have all the answers in the next 2 months locked into place, and 5 years is a long time to distribute all this amount of money. Now, I don't know if CMS intends for us to create this opportunity where local communities can sort of get together and decide what's necessary for their community. But I mean, I think one of the best ideas is to try and to empower local communities to decide for themselves what's the best use of this money. And, this idea of communities coming together, hospitals and FQHCs and other providers to really determine is it technology, is it workforce, is it, section by section within the state, it could differ. So I think this idea of pursuing a grant opportunity really resonated with me.
I'm Eric Hazel from the state EMS office. Anybody that's talked to me lately, I'm a huge advocate for the Regional Medical Operations Center model. I think, it can be the pivot point for kind of bidirectional flow. It can help our local hospitals get out in their community and local healthcare systems improve access for their citizens in their area. On the other side of things, it can also coordinate that patient flow from our rural hospitals, to our tertiary care centers. Fills a lot of those gaps we're talking about. It can be used to move maternal health patients, trauma and time-dependent conditions. Texas model has had excellent success in the mental health field. It's scalable for mass casualties. And then the other thing I like is just the flexibility. I mean, we are doing this on short notice. This can be molded to meet the needs of our state. We're not plugged into a certain model, and it can change as time goes on and what we find works and doesn't work and things like that. So it does give us flexibility as well.
Yeah, this is Mitch Robe. I serve as the Secretary of Family and Social Service Administration. I want to highlight your comment about mental health care. We have spent and continue to spend a fair amount of money on building out a statewide crisis intervention system. So that statewide crisis intervention system can either be supplanted by this or augmented by this, but it needs to unquestionably, Sarah Saylor, I'm looking at you, it needs to be coordinated with this.
100% agree with you.
Sarah, if you want to go ahead, I know you had some other comments, so go ahead.
Yeah, I think the only other thing I wanted to add was from Dr. Weaver's comments, completely agree. I worry about broadband, right? In terms of when you're traveling across Indiana and you're in a lot of these homes, they don't have Wi-Fi. They don't have, we have a lot of areas in the state where it's just technology is not able to be used to its fullest. So that's one concern I have. Two, even for where I live, I'm over 20 miles away from my community health clinic, right? So people in my community, I'm lucky. I have 2-income household, but lots of people don't have cars. They don't have vehicles. They don't have transportation. And so I wonder if there's an opportunity to bring services to them and like being more mobile, like we are with mobile crisis, right? How can we also bring healthcare to them in these small communities across Indiana? So that's just, I think, all I wanted to say.
That's Sarah Saylor, ladies and gentlemen, the Director of the Division of Mental Health.
No, I think tagging on to what Sarah said, just when we met with the IDO, there was an opportunity, a funding opportunity. So they have it all scoped out. Unfortunately, the funding was canceled. However, they have a scope for this particular population and broadband needs and how to access and how to get access. So I think that's worth kind of dusting off and taking a look at that. So I think it kind of ties into what we're talking about. And they already know the cost and its scope. So something for us to consider.
I'm Julian. I just joined the FSSA communications team. My instinct here would be that the IT and workforce would be more scopable to individual communities. Every community is going to need that, but how it would translate, I would think would be more universal.
You want to go again?
I know, I was like, we can probably pass because the Department of Health just gave a presentation, so.
I'm Kara, I'm with Indiana Rural Health Association. I think some great suggestions right now, and where I think we're really aligned is on the technology piece. And I started to say interoperability and infrastructure, which really may be two different components. Infrastructure meaning like physical infrastructure. Interoperability meaning like all things technology. Workforce as well. We've heard from several of our rural hospital CEOs, obviously the challenges with recruitment and retention of providers, but not only providers, also ancillary staff and support staff as well. So I also think that it's important to note that we have significant operational costs to consider here, that when we talk about implementing programs, We still haven't addressed some of the initiatives that we've literally piecemealed together as rural providers, where we don't have the funds to invest into upgrading infrastructure. And so we're trying to do too many things at one time, and it's really watering down the availability of the dollars we have today. And so, when we talk about implementing new programs, we're still not addressing infrastructure. So we need new HVAC systems, we need better MRI capabilities, new digital screening tools that we can't afford today, which is where I think if we can invest dollars to address those types of things, then we can fix the kind of the foundational pieces of what's broken today to be able to invest into the future type of programming that we're talking about that's been discussed already. So I could go on for days, but.
Good afternoon, Scott Smith, CEO at Adams Memorial in Decatur. Top of my list is workforce incentives. Lots of great comments. Dr. Barrett, I really appreciate the comment about not shrinking that footprint we already have and making sure that we support those facilities. I think that the Regional Medical Operations Center supports that, helps those rural facilities feel more connected. But everything we talked about with technology, and we talked about teleconsults and telehealth expansion in the communities, on the other end of that visit is a physician or a nurse practitioner or a PA, and ultimately a physician being responsible for that care. So if we don't encourage that workforce, I assume that we all want those physicians on the other end of that consult to be Indiana physicians. So if we don't support that workforce and support having physicians stay in Indiana to practice, then that system is, I think, not sustainable. So workforce is number one, but it would be a shame, I think, if we did not support the prenatal maternal care and postpartum care as part of this grant initiative. If we left that somehow out of our proposal, out of our options, I think we would regret that in the future.
Hi everyone, Ann Hazlett with Purdue, and I think I echo a lot of what's already been shared. To me, the natural focuses are workforce and technology adoption. In the workforce space, I know there's been several ideas for bigger initiatives, and while we need to be focused, we can't lose sight of the sustainability. I wonder if this is an opportunity to have a down payment on something that we would like to do that will have impact in this area beyond the life of this fund. On the technology adoption side, I know that there's a lot of individual needs for infrastructure, and if I cruise through what was sent to us in the application, it looked like there's no cost share requirement, which I think is good. It enables some big things to happen, but I think we also need to be cautious about any time something's 100% funded. I've seen not good results in former hats that I've had at the federal level with money like that. When there's not skin in the game. So how would we want to scale that? I think if we could hit technology adoption in a way that had maybe a bucket that met individual needs, but then also had something that could be a broader initiative. Maybe it's technical assistance or something that's needed that would have a broader impact than just one-off individual needs. The ideas that were presented by the Department of Health, I know in my role at IRHA, as a board member, we hear a lot about trauma, so I look to the experts we have there. If the regional center is what we need to move that issue forward, I think that's important. And then I really like the capacity idea as something that could have a longer term impact with the regional grant making. The one thing I would say on the broadband side, I would just raise a caution flag that my experience there is that there can be a lot of policy debates and tension that anytime government money comes on the table. So I think we would need to think through that pretty carefully and make sure that we could actually do something that's meaningful and not have a lot of the providers get upset if all of a sudden money is getting dumped into areas that they're planning to serve. And that brings out a whole host of conversation that can get pretty heated from what I've seen at the state and federal level.
Thank you. Liza, you have anything to add? I know it's day
Sure,
two.
day two, legislative director and doing Medicaid policy and strategy work. And just hearing the conversation, thinking about ideas and where investments can be made. I think it's such an important aspect to the program addressing, preventing potential fiscal cliffs, is just the collection of the data and what's driving the outcomes, kind of defining, right, what the end goals are, how do we get there. Dr. Weaver, your team has built incredible dashboards in terms of defining what those outcomes are with Health First Indiana and tracking the progress. So I think the data and outcomes piece to this conversation is really exciting in terms of driving improvements in rural health.
All right, let's go over here to the side row. Anything back here?
I'm Andrea Vermeulen. I'm the director of the FSSA Grants Office. I have no ideas, but I will be helping, and my office will be helping pull those ideas together and make sure that we have a complete and quality proposal. The preferred practice of the Grants Office is to submit 2 days before the grant is due to make sure that everything goes smoothly. So just caution to keep that in mind.
All right. Go over here, Andy.
Yeah, Andy Van Zee with IHA. I think all the ideas that have been suggested are great. I mean, the one area that I think I would expand would be on transportation. We talked a lot last meeting around the need for rural transportation, both from an EMS as well as a non-emergent medical transport. So looking at maybe what solutions to provide greater availability to transportation. The other piece, I think, looking at, as we look at this as a 5-year kind of funding, what happens at the cliff? How do we, looking at the projects in a manner of how do we reduce kind of the operational cost of healthcare in rural areas moving forward? So whether that's on the workforce side or the technology side, but we have to reduce that cost of delivery of care beyond the 5 years. Otherwise, we're just going to hit this same kind of cliff again.
All right, we've hit everybody in the room, so we're gonna transition back online. If there's anybody online who wants to speak, will you raise your hand so we can see that? Can you monitor that?
Nobody has their hand up. Oh, Katrina Norris does.
Katrina.
Hi, good afternoon. Just wanted to really kind of drill down a little bit and not lose sight of the mental health professional workforce side of things. So needing really to grow our own workforce in Indiana. And I know that recently our speaker had a panel discussion with other state leaders about talent pipelines that were successful in Pennsylvania, for example. So I really think we, as a working group, need to not forget the mental health professionals in the side of this as we make decisions. And I have a more specific plan that I have sent to Tara.
Okay.
Who are you?
I'm sorry, I'm Katrina Norris. I am the executive director for the State Psychiatric Hospital Network.
Thank you.
And do we have any other hands?
Yeah, we have Andy Mulvey. But we can't hear you.
Andy, you're muted.
How's that? Can you hear me now? Can you hear me?
Still can't hear you.
All right. 1 minute. I'm going to join with my phone.
Nobody else has their hand up at this point. So while we're waiting for Andy, Andy, when you mentioned transportation, we did not mention, we have a meeting set up with NDOT to discuss some of their initiatives, funding, and we didn't know until the application came out if we had an opportunity to enhance programs that already exist or if new programs or new initiatives were part of this. And I believe I read that we are able to enhance some programs. So I think that, we can look at that as well. So if there are any other organizations that we haven't mentioned today that we need to be engaging, please let us know so that we can start those conversations now. Again, time is of the essence. So there are several of us that are going to DC. There's a meeting, it's an all-day meeting on September 30th, where we'll get together with CMS as well as other states to really have roundtable discussions about some ideas and initiatives across, so we can leverage kind of what we've been talking about with other states, and then we can hear, as you mentioned, as Dr. Weaver mentioned, she's had conversations with other states as well. So we're hoping to get a lot of good ideas from that. That's not till the week after next. So again, right now we'll be formulating the application and reaching out to different groups to help us fill in the blanks, especially for data. We're not going to reinvent the wheel. We know there's data being collected on a lot of these points, so we just need to make sure we're accessing the right points.
Andy?
Did we get Ian back?
Yeah, Mitch and Tara, can you hear me now?
Yes.
Great. Sorry about that. Thanks for the invite. And my name's Andy Mulvey. I'm a practicing emergency physician in Indiana, and also part of a company, Community Hospital Partners, that partners with states and rural health systems to really just a micro-sized, the micro-hospital model, looking at ways to improve efficiencies, looking at care delivery. We really, I think, check most of the boxes in the 5 goals and strategic goals for this program. Looking at ways to improve access to care, improve quality of care, certainly develop a more financially stable and secure long-term model for our rural health facilities. Looking at how do we create a health service, a rural health and community hospital that allows us to continue to have that front door access to the emergency medicine, some inpatient care, but really look more critically at the services we're offering and how do we make it a little more financially stable and secure down the road. And this can include anything from just right-sizing some operations, looking at overhead, looking at revenue, all the way to creating new micro-hospitals, which again, we understand there's new facilities are not part of this proposal, but certainly utilizing existing licenses for stabilizing and ensuring we can continue to keep these rural sites open and operating. So, our model also includes a lot of telehealth. I think all that makes a ton of sense for the long-term needs. We also have had a lot of great success with provider recruiting as we, facilities tend to be a little more attractive to work in and become a little more technologically advanced. That will certainly help to draw more of the workforce. So love to have an opportunity to discuss more, but just wanted to introduce myself and the concept.
All right, do we have anyone else online?
We do, we have Julie Reed.
Julie?
Hi, everybody. Julie Reed, Indiana State Medical Association. Appreciate all the important work this group is doing. We've not submitted any kind of formal proposal yet, but I think are really focused on kind of the workforce piece, not just kind of the workforce pipeline, but also kind of workforce wellness. And I think we'll have some ideas around that we're happy to share in more detail.
Yeah, we would love to see the detail.
Thank you. Appreciate it.
That's all we have. Is there anyone else? Nobody else has raised their hand.
Okay, so things are going to move quickly here over the course of the next 5 weeks. So if you have specific suggestions, please share them with us. We have some other meetings coming up, but we're going to have to begin writing the document like tomorrow to meet that deadline. So I'm glad that we started this process early before we knew exactly what we needed to do, but now we know exactly what we need to do, so we need to do it. So any other thoughts before we close?
Can I ask just a question? So I mentioned I'm also on the board for iHigh, and they posed a question about whether it would be helpful for them to write a proposal with some fiscals and send it to this group.
Yeah, it would be. I mean, one of the things that Dr. Weaver and I have talked about, and our newly minted legislative director is going to be working on, is making making the electronic medical record available to us as a condition of participation in Medicaid. As you are certainly aware, we don't generally have that information today. The information we have is claims data, which is not nearly as robust as the other data. We've met with several AI vendors who perceive that they can use AI to drill into those electronic medical records and discern whether or not we are using whether the amount of care that's being provided corresponds to the risk that patient is in. This is particularly the case in the pathways and the fee-for-service population. So yes, it would be helpful, and I'm remiss in not telling Kansky that.
I will let him know today.
I have questions on that, not just iHigh specifically, but I've gotten a lot of proposals submitted my way that have said, oh, push this through, push this through. I don't know if they're truly, I just would strongly encourage that if a proposal comes through, that it's taken back to the rural hospitals, the rural providers to say, does this make sense? The only reason it came up from an iHigh perspective is if it truly integrates with the EMR, or if it's a service you have to purchase. Because today, a lot of our rural hospitals do not access iHigh because you have to log out of your system, log into iHigh, and it doesn't interface. And so I just want to be very careful that we don't create more expense for the rural providers when we think it's going to resolve and address the solution, but it costs more money in the end. So I don't know that that's the case for iHigh. But I know other vendors are in the same situation. Like AI is another great. We can provide AI tools, but if I have to purchase them, then for a rural hospital, it may not make sense.
Could we build that into this grant though? That interface that's needed?
In theory, in theory, it sounds like it. You know, every EMR. I can remember when I was documenting on paper, and electronic medical record was like every system's going to talk to everybody, and no one does. So and that's the challenge we're still in today. So if it can build an interface, but we literally have hospitals who have 3 different EMRs and none of them talk internally to each other. So if we talk statewide and how we pull that together, I mean, maybe it exists and we just haven't figured out. I just throw some caution to the wind there that
no, I think those are great
it can
points.
result in greater expenses if we aren't careful to make sure we talk to and I'm sorry, I'm pointing to you because you're literally a rural provider, to make sure it makes sense.
This is why I think technology and interoperability need to be top of mind, because these challenges are really hindrances.
Yes, sir.
Do we have a sense of how many different initiatives the state would like to have in the proposal? Or how many?
Well, okay, I'll speak for myself, but that doesn't mean that I won't be overruled. I would say fewer really good ones than pouring water on the prairie. But I think we need to do 3, right? That's the minimum.
We need to at least address 3, yes.
Right, so.
But they could be combined, so you could have one initiative that covers 2 or more.
So, I mean, I'll admit to being surprised when I got your letter, I don't know, 6 weeks ago. When I asked you guys to send me a letter about what was, and the top thing on the list was technology. That was not my expectation. So it's interesting to me that that was there. So if people want to have like lots of stuff and pour water on the prairie, doesn't sound like it.
Just speaking from the experience with the ARPA funding and doing kind of the same thing, like that doesn't work.
Give out a lot of little bit of money here and there.
Yes. you dilute your efforts so much that when you come back, you don't have the results that you're hoping in certain cases. And so I think it's really important to focus really hard on a few and get everybody around those few.
And making sure the work's sustainable for the agencies that are going, that we're going to be leading this, that we don't find ourselves drowning at some point.
And I think it'd be helpful for the group if we knew how soon they wanted to narrow it to a few as well. You're asking for proposals now, and we get lots of different proposals from lots of different folks, then.
I mean, I hadn't planned to do this, but I will. I hadn't planned to run FSSA, but I am. I guess listening to the conversation, the things that I came away with, and you guys, and particularly people online, tell me if it is the ER stuff that you referenced, right, would seem to have a lot of resonance. The infrastructure seemed to have a lot of resonance, and I think, you made the point about prenatal care. We spend a lot of money at FSSA. The most important dollar we spend is on prenatal care, right? Because so we would want to integrate it with the plans more effectively, and I would kind of I would want significant input from the plans and from you specifically on that. But those kind of what the three things I heard. That doesn't mean it has that I'm right about that. My hearing may be bad.
And I think, we were kind of hoping that the application was going to drop when we expected it to, which was yesterday. Knowing this, we have this meeting today, but I think it was important to then, regroup from where we were last time. And really, now we really know there's a lot of information required with every initiative. So we have to be pretty strategic in which initiatives that we choose to put forth. So I think over the next week and a half, we will be working with IDOH very closely to really kind of hone in on maybe a guideline of where we think we're going to go with this, and then we meet again in a couple of weeks. So again, we don't have a lot of time, and that's why, but this was really helpful, I think. I think everybody kind of sees kind of where we're going, and there are a lot of really great things that we can accomplish, but we just have to be very structured in how we approach it.
All right, so let me put some more work on your plate, Kara. I'm really good at that.
Love it.
And that would be, maybe we outline maybe we provide a framework for what we think that's going to look like, and kind of get people's input next time.
Yep.
Because there may not be a fourth time.
Right.
Right. I mean, the frank reality, and I mentioned this at the beginning, which was we're gonna be collegial and polite at the beginning, and then we're gonna have to just run like hell, right? So following the next meeting, the run like hell part probably starts.
And I think for the working group, it's going to be really important because we are going to lean on the working group as we formulate this outline. We're going to need a lot of people filling in the details of what we need once we determine what those initiatives are. So we'll kind of get to that point where these are the initiatives, and now help us figure this out so that we can submit an application that's approved. So pretty straightforward. We're looking at some maybe listening sessions in a couple hospitals across the state. So we're working on hopefully getting that scheduled soon, along with a virtual listening session. Again, community engagement is really important, and it's required in this.
And when's the next meeting?
The next meeting is 10/7. Yeah, so in a couple weeks.
So if we could just leverage that intervening time as much as possible, if there's any opportunity to send us emails and
Yes.
gather input, I think I'll be
I
happy.
think we know a lot more now, and so I think you'll probably be hearing from us all.
I mean, for folks who are just looking at it, I would probably like the application. Probably the most important part is like page 64 and on, which is the appendix, which actually has how they're going to be scoring everything. And so,
And I think that's where the input that we get from individuals is really going to be helpful, because we can have a lot of stuff on paper, but it's the actual practical application of what we say we're going to do and how we assess that and how we assess outcomes. I think, again, that's the most important thing, because we don't want to have a situation where they will come back and get the money if they're not happy with how you used it. So I think Paul would agree. You don't want to be in that situation. All right. Feel free to stick around if you have any other thoughts or suggestions. If you're online, use the email. You can contact me directly, tara.morse@fssa.in.gov. So however you need to get the information, I'll take it.
Move in.
Thank you. Let the word out.
Didn't even attempt to pack it.
Hey, Eric, will you end the meeting?